We're going to start with Dr. Natalie Sanders. She's an assistant professor within the Division of Geriatrics at the University of Utah. 3 years after opening the University of Utah Faint and Fall Clinic, Dr. Sanders became the medical director. In 2017, she narrowed her practice to caring for geriatric patients. So her current clinical practice at the University of Utah Geriatric Clinic, where she specializes and focuses on faint fall and frailty symptoms, among many other professional responsibilities. So hopefully I didn't mess that up too much, Natalie. And Grayson, I didn't have an introduction for you. So if you want to just take a few minutes to just give us an introduction about you, where you work, and your history.
I'm Grayson Doar, and I'm a physical therapist with the University of Utah Balance and Mobility Clinic. I specialize in dizziness, all kinds of dizziness, and I specialize in falls prevention. And so my passion is to keep our senior population as independent and as healthy as they can possibly stay, so they can stay active and enjoy their life. So that's me.
Thank you so much for having me. Fall prevention is, just like Grayson, is a real passion of mine. A challenging passion to do day in and day out, because unfortunately a lot of patients who end up getting interested in fall prevention, it's after they've already had a major fall. And that becomes quite challenging, because that usually means that there's been lots of different risk factors that we have failed to address. So that is really my goal today, is to try to talk about how we can prevent these falls, particularly the serious falls happening in the first place. So with that, I'll go ahead and get started. So learning objectives, just very quickly, we'll just review the physical and environmental fall risk factors. And I really wanted to try to highlight some specific medications associated with falls, because I think that that's a area of low-hanging fruit. But I wanted to just review some practical interventions that we can, as healthcare providers, professionals can put into practice today, and as well as older adults can put into practice today. So first of all, why are we talking about this? I think this comes as no surprise that falls are an important thing to address among our older adults. Approximately a third of community dwelling older adults, and that means patients 65 and older, fall each year. It accounts for at least 10% of ER visits and 6% of hospitalizations among Medicare beneficiaries, so adults 65 and above. And this is old data, it's costly. And then, of course, as we all know, falls are associated with high morbidity and mortality. It's really important to emphasize that when a patient comes in with a fall, and specifically with a hip fracture, less than 25% of them will return to their baseline level of function at 1 year. So what that means, what that translates to, is that if prior to the fall they were using a walker or a cane, let's say a cane to get around, and they were needing some help with some help with supervision at home with medications, or driving, that less than a quarter of those patients will even return to that previous level of function. So it's really important. Again, it's a leading cause of injury-related morbidity and mortality, which is, of course, why we are talking about it today in the trauma series. The other thing to remember about falls is that falls beget falls. So this is a well-described cycle that happens where a patient or a client has a fall, and then they develop a fear of falling, and so then they restrict their activity even more. But ultimately, at some point, they're going to have to get up and use the bathroom or go make a cup of coffee or whatever it may be, and that ultimately increases their risk for falls again, and they fall again. So it's this very vicious cycle, and preventing the falls in the first place is really where the key intervention is. when we're talking about why older adults fall and how to prevent them, it's really a combination between a lot of different factors. And this is why makes it so challenging to, once a patient ends up with a fall or multiple falls that have put them into the hospital, it's why it is so challenging to kind of break that fall cycle, is because usually by that point, there are lots of different factors coming together and leading to this fall. So the way I describe this to patients is that it's like a lot of different factors coming together and causing a perfect storm, and then you fall. But it needs to be, it's the precipitation and what is the weather doing like that day, and the barometric pressure and all that. And you've got to address all of those different areas in order to be able to prevent the fall in the first place. Some key factors that really lead to falls and are fairly easy to address are addressing gait and balance impairment, addressing environmental hazards, and then looking at drugs. So those are kind of the three practical areas that I'm really going to focus on today. When we're assessing fall risk, there's a very simple screening questions that you can go through, and many of you may already know these, but these come from the American Geriatric Society recommendations. And it's basically, have you had 2 or more falls in the last year, or do you feel like you have problems with your walking and your balance, or your balance? And if they answer yes to one or both of those, or they are presenting with an acute fall, then of course they deserve a comprehensive fall assessment. That is what my clinic focuses on, geriatrics clinic, and then I'm the director of the Faint and Fall and Frailty Clinic, so that's a good resource for you. And then otherwise, if they are an older adult, again, 65 and above, then always trying to think about fall prevention. There are a cajillion different research articles out there about how do we assess patients who have fallen, and what are the best interventions to do to help reduce falls among older adults. This is actually an old study here, but it still rings true. It's back from 2003, and again, I just wanted to highlight those 3 areas are really the areas that you get the biggest bang for your buck. So really focusing on strength and balance training, reducing home hazards, and discontinuing high-risk medications. So what are those medications? This is a long list, to be honest, much longer than what's on here. But the ones that I always like to really emphasize that seem to be frequently missed or not understood as high risk factors for falls in older adults are over-the-counter sleep aids, specifically anything that has diphenhydramine in it, which is Benadryl. So many older adults have difficulty sleeping, and they won't say that they're taking a sleep aid because they don't consider Tylenol PN as their sleep aid. But that is indeed a sleep aid, and it is fraught with all sorts of side effects, and it is the number 1 medication in geriatrics that makes a geriatrician's stomach just turn, just hearing it on someone's med list. So that's a big one, and that's an easy one to kind of take away and really try to avoid. I know that's one that is oftentimes, we have new interns in the hospital this time of year, and they may get called by nursing to say, hey, I need a sleep aid for this patient. And they might suggest diphenhydramine. And for the nurses out there that do inpatient care, this is a great opportunity for you to educate them that that's a really poor choice, and perhaps something like melatonin would be a better choice. Blood pressure medications can increase patients' risk for falls, of course, because they're associated with low blood pressure, and orthostatic hypotension, or a drop in blood pressure when we stand up, is very common as we get older. So older adults, their blood vessels get stiff as we get older, and so it makes it much more difficult for their body to compensate for changes in posture. And then, of course, we give them a whole bunch of medications that are also supposed to lower their blood pressure. And then they may not be drinking as much fluid as they should because their thirst mechanism is impaired as they get older. And so that normal drive for thirst that we have when we're younger, that system doesn't work as well in our brain as we get older. And so when patients say, well, I don't drink because I'm just not thirsty, it's true, they aren't thirsty, and they're not just trying to be, non-compliant patients. It's truly that they don't have a drive to drink fluids. And so just really educating them on making sure they're staying hydrated. Anti-anxiety medications, specifically benzodiazepines such as alprazolam or lorazepam, are big offenders for falls. Narcotic medications, some of the antidepressant medications, particularly at higher doses. So your selective serotonin reuptake inhibitors, things like sertraline, citalopram, Paxil, those kinds of things, and then anticonvulsants. I mentioned that those were that there's a lot of medications that can cause or increase patients' risk for falls. I'm not going to go through this whole table, but I just wanted to share this with you. This is the American Geriatric Society Beers criteria, which is the medications that are potentially inappropriate to use in older adults. And table 3 of that document breaks down medications that are ones that you would want to avoid based on the medical syndrome. So, for example, syncope or fainting here, and then falls or fractures. So this is available online for free. You can get it as an app on your phone. So this is it's a nice resource to have. Okay, so what about home modifications and environmental modifications? So I'm just going to go through a couple areas. And just easy things to think about. This is where an occupational therapist can come in and help do a home safety assessment or even physical therapy. But we can even be talking as other providers, we can be talking with patients about this, or we can be thinking about this in our own homes or in our parents' homes, for example. So, making sure that rugs, if they have to have rugs, I know my mother-in-law is just absolutely 100% attached to her throw rugs, but at least making sure that they have kind of a no slip thing under them. I love this picture of these stairs because in my mom's house, not that I'm going to spend the whole time talking about my family, but my mom loves to have everything white. So everything is white in her house. There is no contrasting colors whatsoever. And it makes it, you can imagine in patients that have, as you get cataracts and your lenses in your eyes get cloudy, which is what cataracts do, it makes it much harder to see the changes. And so you need to have some kind of demarcation, whether it's that this is done really nicely where it's done with different colored wood, but you can put tape on there, fluorescent tape or black tape on stairs just to highlight the difference. Once you start kind of thinking about things, you'll notice when you're walking around in the community, how there are clearly some businesses, and even in our own hospital, there's clearly some areas in our hospital at the university that have done a really nice job at making sure that we have age-friendly floors, and the tile is not all exactly the same color. There's at least some contrast, and then other areas where it's not done so well. So something to think about. Of course, bathrooms, there's a whole bunch of aids that can be placed in bathrooms to help with fall prevention. Elevating the toilet seat, for example, making sure that there is a shower chair. There is not a big, huge threshold to step over here. This is a walk-in shower, which is also nice. There's grab bars around, and they're at an appropriate height. So all of those things are nice things to do, and certainly less expensive than a hospitalization for a hip fracture. This is my dad, and I just liked these pictures. Again, this is my daughter Ruby 4 years ago, but I like these pictures because you can see that even just things like chair heights are really critical. So, my dad has pretty good strength in his legs, so he is able to get out of this chair. But you can imagine if you have someone who has been getting weak in their legs, or maybe they've already had a fall, and so now they're limiting their activity. Well, then they go to try to stand up out of a chair like this, and it's quite a bit more difficult to get out of a chair when their knees are up to their chest, as opposed to here where it's still a hard chair. There's not arms for him to push off of, but at least he's not sinking down where his rear end is below his knees. So just again, things, kind of simple things to think about. I have a couch in my house that is super soft and old, and anytime my parents sit in it, they always have a hard time getting out of it, just because, again, they kind of sink into it. So, even if you can put pillows or something on that, which is what I do when my parents and my in-laws come, so that they're not sinking down so much. And then, of course, other things like, making sure that electrical cords are out of the way. And, this becomes critical with, oxygen cords. That's another kind of safety thing. And in the hospital, of course, dragging around IV poles, all of those things can be fall hazards. We talked about adequate lighting. And then the last thing is just really using common sense. So, getting grabbers for your patients or for your loved ones, getting a pill box and helping them to supervising their medications. I had a patient yesterday who told me that the only time that she stands up on something is that she has to, reach her hummingbird feeder, and she only has a rolly stool that she can get up on, and to be able to change the hummingbird food. And so we had a discussion yesterday in clinic about how perhaps she could get one of her grandsons to change that for her, and then move the hummingbird feeder so that it's a little bit lower, so that she doesn't have to get up on a step stool that has wheels on it. Shouldn't even be getting on step stools, period. So this is a fall prevention home assessment chart that I oftentimes will hand out to patients. And it's just an example of a checklist of all of the different things that patients and their families can do to try to help ready their house to be more fall safe. It's almost like, getting your house child safe. It's getting your house safe to be able to prevent falls. And then the last thing is, of course, one of the best things that you can do to prevent falls, apart from changing the environment and modifying the environment and working on environmental factors and addressing medications, is of course getting active. And this is where Grayson is going to come in and give more details. But it doesn't take much. I mean, these are a couple of the things that I encourage patients to do. But the important thing is getting out there and really emphasizing to patients that it is not just strength, but it's also incorporating balance into their exercise. program. So walking is great, but it doesn't do a whole lot for balance. So really challenging them to incorporate some balance exercises into their daily exercise program. And with that, I'll stop and I guess hand it over to Grayson.
Thank you.
One question that did come up, Natalie, was your fall prevention, that invoice that you had on there.
Mm-hmm.
Is that on Pulse, or where can that be found?
Oh, you know what? That's a great question. And it is not on Pulse. It should be on Pulse though. And I love that idea. We have those in clinic, and they were actually made from a grant. That's how that project was funded.
Natalie, if we can get that copy too, when Emily and I post the recordings of the summer prevention series, we can definitely add that attachment so people have access to that as well. If that's
Okay.
right.
Grayson, you're on.
Okay. All right. I'm here. So again, as I said at the beginning, I'm a physical therapist. And so my portion of this is really going to focus on the physical function portion of falls, and the physical tests that are associated. But the first thing I wanted to say is one of the big things about falls is just education to everybody in the community. So certainly education to the patient, but education to their family and their friends. And one of my big pushes is to get rid of the stigma associated with falls. I think especially for a lot of our community dwelling adults, they don't want to talk about falls because they think that it's not going to happen to them, or they're scared they're going to lose their independence if they start to talk about falls, or to go to their primary care and to talk about falls. But if we can talk about falls as much as possible, then we can reduce the stigma of the falls, and to let people know that although balance and a decrease of balance is almost inevitable with aging, falls do not have to be inevitable. And there are things that we can do that can either prevent the first fall in the first place, or if someone is falling, to intervene so that future falls are not as likely to happen. And so if we can have that conversation, instead of someone saying, I'm fearful of falling, oh, well, you lose your independence, you lose your house, you have to go into assisted living. Someone can say, oh, I'm fearful of falling. Let's intervene before you lose all of that independence. And I would like to talk briefly about why I say that a decrease in balance is almost inevitable with advanced age. So back to all of our kind of anatomy back of yesteryears, if we reflect back, there are 3 systems in our body that really contribute to the balance. And the first is vision. And Dr. Sanders talked about this with the cataracts. And so we all become more visually dependent with our balance as we age. And if we throw on top of that cataracts or macular degeneration, or any of these common factors that can reduce the vision, well, that starts to chip away at the balance input that our brain receives. The second balance system that helps with our brain is going to be the vestibular system, or the inner ear. And there are a lot of things that can happen with this inner ear, especially in the 65 and older population. And so some of these you may be aware of. BPPV is when you get the crystals lost in the ear, and that provokes a vertigo sensation. Vestibular hypofunction, either due to a neuritis or a schwannoma on the nerve. Meniere's disease is also something that happens. Or just general disuse atrophy. We know that our body is a use it or lose it kind of system. And if we're not out there continuously challenging our balance system, but our vestibular system itself, then our brain stops relying on it. And then the input that's coming into the vestibular system for the brain to contribute to the balance, again, we start to chip away at that. And then the third system that contributes to our balance is the somatosensation, or what I tell my patients, that feeling of the floor beneath your feet. And there are lots of reasons that people have reduced somatosensation, but the most common one that we see is a peripheral neuropathy. And so if someone has cataracts, okay, and maybe they have a history of BPP vertigo and they have peripheral neuropathy due to type 2 diabetes, well, they don't really have a whole lot to hang their hat on when it comes to balance, okay? But there are things that we can do to intervene on any of those to help this person have better balance so that we can decrease their risk of falls. And again, as I said, many of these get compromised as we get older. So the first thing that I would like to talk about is a couple of super simple tests that can really be done any place, anytime, anywhere. These can be done with your family members. If you have elderly parents out there and you want to see what their fall risk looks like, these can be done in front of the family. But these also are chosen that they can be done very simple in a clinic. So just a brief screen to look and see what someone's fall risk might look like. The first one is going to be the 5-time sit to stand. And the one thing I didn't talk about a second ago is strength. And we know that strength is a component of balance. And if someone doesn't have adequate strength in their legs, then it does put them at an increased risk of falling. And so a super quick down and dirty test to assess if someone has adequate functional leg strength is a 5-time sit to stand test. And luckily, the test is actually in the name. You have someone who sits in a standard straight back chair that's about 17 to 18 inches tall. And then what you do is you have them put their hands across their chest so that they're not looking to cheat with their arms. And they stand up and they sit down 5 times as fast as they can. And what we know with the 5-time sit to stand is that people who have balance disorders, it takes them longer to stand up and sit down 5 times than it does the control population. So if someone can stand up and sit down out of a chair 5 times in less than 12 seconds, well, that indicates to us that they have adequate leg strength to contribute to their balance. If it takes them between 12 and 15 seconds, then what we say is more testing is necessary. We need to go a little bit more in depth to see if we're really looking at an increased risk of falling with them. But if it takes someone 15 seconds or longer to stand up and to sit down from a chair 5 times, that does flag them as having an increased risk of falling. And then I did put here the website. If somebody wants to refer back to this website, this Shirley Ryan lab, the rehabilitation measures, does a really good job of walking through this test. But all this takes is a stopwatch and a chair to assess someone's strength. And then another super common, super fast balance test that we can do is called the timed up and go. This test can assess mobility, balance, walking ability, and fall risk. And again, all we need with this one is a chair and a stopwatch. And so the other two nice things about these two tests is it doesn't take a lot of space, okay? So when I'm assessing a patient, I try to stay in my little treatment room, and it's a pretty small space, but you can do these with about 10 feet of space. And the other fun thing about the timed up and go is that someone can use an assisted device, okay? So if they usually use a walker or a cane, they can perform the test with an assistive device. So again, the patient sits in the chair with the arms, same thing with the 5-time sit to stand. And then you measure 10 feet and you put a piece of tape 10 feet away from the chair. And then what we ask the patient to do is to say, when I say go, I want you to stand up from the chair, walk to the line on the floor at your normal pace, turn, walk back to your chair at the normal pace, and sit down again. And so this is a self-selected walking speed. So it kind of measures strength, their ability to get up and get down out of the chair. There is a little bit of a measure of gait speed, how long it takes them to get to the line and back again. And then how they can turn and pivot, which we certainly do all the time when we're walking. And we know with the timed up and go or with the tug that if it takes an older adult, so 65 and older, longer than 12 seconds to perform it, that this does indicate that they are an increased risk of falling. And again, I have the website for the Shirley Ryan Lab there that you can go and refer back to if you're interested in doing this. And one other tool that I was going to talk about is the STEADY tool. So hopefully you all are aware of the STEADY tool out there, but this is a tool developed by the CDC with the goal to help healthcare providers assess the fall risk of their patients. And so the STEADY tool does incorporate 3 of these core elements: a screening to see if we need to assess their fall risk, some assessments themselves, and then some intervention guidelines. So if you do feel like the patient is at a risk of fall, some things that you can do. The STEADY does include many of the previously mentioned fall risk assessments, some of the ones that Dr. Sanders had talked about with the med check and their home environment, their vitals, looking for the orthostatic stuff, if that is applicable to the patient. and then the physical assessment that I just went over. The one thing that the study tool does not include is a cognitive assessment, and we know that cognitive impairment does also indicate an increased risk of falling sometimes also. And you can link out to the study tool if you would like to through that website. So again, as Dr. Sanders had talked about, strength and balance exercises are one of these big kind of things that we can hit. I mean, we can, in physical therapy, we can increase your strength really effectively, and we can teach people different balance strategies to increase their balance. So I wanted to talk about some very specific strength exercises that you can do just as someone who wants to keep their adequate leg strength so that you're not in an increased risk of falling. But if you do have somebody in your life, or you do have somebody in your clinic that you want to give just a couple of really simple exercises that people can do anytime, any place, anywhere, I wanted to go over a couple of those. So the first one is the sit to stand exercise, okay? And this is a really simple exercise in theory to perform, okay? All you're doing is as you can see with this gentleman, is standing up and sitting down, arms across your chest to keep you honest so that you're not tempted to push off onto your legs. And many times I do ask my patients to get to the point that they could do 20 of these up and down, 20 times without stopping and resting. So because I'm a physical therapist, because I'm a falls prevention specialist, because I do these exercises all the time, I do a sit to stand exercise multiple times a day. Like I do this all the time with my patients. And 20 of them is not that easy. You know, my legs might be a little bit tired. My heart rate might get up a little bit. So it's not easy to perform 20 of them in a row, but the basic principle of the exercise is really nice. The other thing about sit to stand exercise is that I was at a lecture a couple of years ago, and they were saying that the average adult, 65 and older, stands up and sits down through a day about 70 times. And that's not just getting out of a chair. That's going to be getting out of a bed, getting out of a car, getting out of a restaurant booth, getting out of a dining room chair, or even getting on and off the toilet, okay? So this is a great exercise to help with strengthen the legs, but it's also a really lovely functional exercise that we all do all the time. And so to be able to stand up and sit down easily is super important. Another exercise to do is just going to be a simple double leg heel raise where you're standing on the floor on both of your feet and you raise your heels and you go back down again. So the calf muscles, the gastroc and the soleus, are very important muscles when it comes to strength and balance. Okay, so if you get these external perturbations or you get off balance, to be able to have control of the ankle and of the knee through the calf muscles is super important, so to keep that strong. So 20 of these once a day. And then a couple of other strength and balance or strength exercises is just standing and kicking your leg out to the side. And when I have my patients do this, and I know I'm kind of small, but if y'all can see me, to kick your leg out to the side. And if you can see, what I'm doing is I'm kicking my leg out to the side, and I'm not actually putting my leg down. I'm actually just balancing on my left leg the entire time. Our patients can stand on both legs and tap the leg out and tap it in, okay? Or they can kick out and tap it in, and kick out and tap it in. So it's a nice exercise because you can vary the exercise and the difficulty based on what the patient is able to do. So obviously, if I never put my foot down, it's harder. If I put my foot down with every movement, it's a little bit easier. And I do like to encourage someone doing this without touching anything, okay? So they're standing and balancing independently on their leg without any upper extremity support. And the same with the hip extension, to kick out back. I didn't have a picture of the exercise without someone holding on, but I do, again, encourage people to do this without touching anything with their hands or their upper extremities, so that we can become confident in our legs and our feet ability to keep us balanced. And then it becomes both a balance exercise and a strength exercise. And then walking, I recommend everybody to walk. Walking is the most functional thing that we can do. So along with the strength and balance, to do some walking exercises. And then last but not least, obviously some super simple balance exercises. So as I talked about kind of previously about the three systems in our body that contribute to balance: the vision, the vestibular system, the inner ear, and then somatosensation. As we get older, we do have a tendency to become very visually dependent on our vision, on our balance. And you can see that if anybody's kind of in a position where you can stand up and balance on one leg and then you close your eyes, how much that does increase the sway. And so what I do stress to my patients is this need to do balance exercises with your eyes closed. Because if I'm standing in a challenging balance position, so if you look at the first picture here, the lady is standing with her feet together, so that decreases your base of support. So stand with your eyes open for about 30 seconds, but then close your eyes because you take the vision out of it. And once the brain isn't allowed to use the vision for balance, the brain's going to start tapping into that vestibular system and saying, hey, what information can you give me? What can I learn from you? And it's going to start tapping into the somatosensation from the feet and saying, hey, feet, knees, hips, what information can you give me so that I can stay safe? I do recommend that people do this in the corner of a room, because most people will fall backward or side to side when you're in balance situations. And if you're in the corner of a room, you can stay safe with that. If that's too easy and someone can stand with their feet together, eyes open and eyes closed, super simply without any sway, then we can start to kind of up the ante a little bit. We can make it a little bit harder. And we can make it harder with this half tandem stance, where someone can move one of their feet about half of a foot length forward. And then this again decreases your base of support and makes it a little bit more challenging to maintain your balance, both with eyes open and eyes closed. An even harder way to do it is that full tandem stance, or that kind of field sobriety test that we all kind of dread because it's really hard to stand in a heel-toe position. But with the full heel-toe position, both eyes open and eyes closed, and then both feet in front. So you can start with your right foot in front and then go to your left foot in front. And then another way that you can do a balance exercise is to stand on an uneven or compliant surface. So the minute you're on this uneven surface, okay, it's kind of like mimicking walking across grass or trail hiking or being on gravel, where your brain doesn't get the somatosensory input from the feet. Okay. And so then at that point, you only have your vision and your vestibular system available to you. But if you're on this compliant surface and then you close your eyes, your brain has nothing but to tap into that vestibular system and to see what information it can give you. Obviously, this is pretty advanced, and we wouldn't want to do it for anybody who would be unsafe. But it is another way to challenge your balance. And then I also wanted to talk a little bit about some community programs that are available for people. So one of the big ones out there is the Stepping On community program. This is an evidence-based falls prevention program. It's once a week for 7 weeks, and it does offer your older adults information, strategies, and exercises to reduce their risk of falling. But the other thing that the Stepping On program does really effectively is it increases someone's confidence in their safety. Okay, so we know that fear of falling is one of the big indicators of a risk of fall. And so if we can increase someone's confidence that they are safe, that inherently will decrease the risk of falling. So some research that was done in Australia shows that with the participants that there's a 31% reduction in falls after someone participates in the Stepping On program. And some studies in America show that it could be as great as a 50% reduction of the falls. And then I did give you a link so that you could use it as a resource to see if what Stepping On programs are out there. Obviously, in the time of the viral pandemic, I think that they're probably far and few between, but hopefully they get more and more as we work our way out of this. And then another community program is the Otago Fall Prevention Program. This was originally done in New Zealand, and it is another evidence-based fall prevention program, and it focuses on strength and balance retraining. It does include 17 strength and balance exercises. with the encouragement to do these exercises for about 30 minutes 3 times a week and walking for 30 minutes 3 times a week. And then I included another link with this. And then obviously, why I have a job, physical therapy. And so at the beginning of my slide, I did put my email address and my phone number on here. And so if you ever find anybody or you have any questions about physical therapy and what we do to intervene with the patients, or if something would be appropriate, please don't hesitate to reach out to me. And there are some resources.
Excellent. Thank you so much. That was actually, I'm breathing hard because I was doing your exercises while you were presenting. There were a couple questions. One was, Jamie, you read it because I'm not having it.
So my thinking is a lot of the people that have joined us are either emergency room nurses or EMS providers. And most of the time we're seeing people that have had an injury or they have mobility or range of motion restrictions. And so just giving us some tips and tricks, either from you or from Natalie, for how to, help these people be safe when obviously we're still going to refer them to the faint and fall clinic or that, but things that we can, educate them on to go home safely, or if an EMS provider is responding to a home with a fall, and they know they have mobility, just certain tips that they can give those people when they're responding or when we're leaving from the hospital with mobility or with range of motion restrictions.
And so, Jamie, just for clarification, specifically for like those exercises I was talking about, or any kind of modifications?
So thinking about, if we have somebody that comes in and they recently had a knee replacement, and we're worried that they fell at home and they can't do a full sit to stand, would it be use a higher chair? Those kind of tips that we can modify those exercises when they don't have that full range of motion already.
Yeah. And so, so if the chair is too low, the recommendations that I normally give is to put pillows in a chair. Okay. So I still want them to stand up and sit down out of a dining room chair is the best way to do it. And you can bolster it up as high as they need to with 2, 3, 4 pillows. And then what I tell them is, if once you can do 20 of them with 4 pillows, take a pillow out. Now you work at doing it with 3 pillows and take a pillow out until you can work your way down so that you can limit that. With the other strength exercises, the modification that you can make is that just allow them to use a countertop support. Okay. So all of those with the double leg heel raises, with the standing hip abductions and extensions, all of those, the modification there is just to touch something with your hands. And that can get them moving and doing something in the interim if they do need further care, until they can get the further care from there.
Fantastic. And I would definitely say, with what Natalie touched on for our EMS providers that are out there, if you're seeing those fall risk hazards in people's houses, because you are the ones that are responding to houses and seeing these fall risks, maybe before they're actually getting an assessment done by, like a faint or fall clinic or, going to their primary care, is definitely tell them, hey, I've just noticed some fall risks in your place of living. We would definitely, advise you to get these looked at. So I think this is definitely applicable to our EMS providers out there to notice those before they're even assessed by other means.
Yeah, there's also a couple of questions. Do you do fall referrals from the emergency department, or only if they're admitted? And is there something we can do to help from the emergency department, since many fall and then go home?
And so actually here at the University of Utah, we do have a physical therapist in the ED. He was placed there mainly for low back pain and to intervene with low back pain. But he does do some falls assessment and then some acute dizzy assessment. And so if he's there, the ideal is that he does a triage and then can refer them to the appropriate, whether it's a community program or home health or an outpatient, what goes on with there. And so we do take referrals straight from the ED, and we do get a fair amount of those. But one of the big things that the ED can do is I sit on a task force, it's a state task for the Fall Prevention Alliance, and we have a brochure that is available. And what the brochure does is it kind of goes around falls assessment, but then it also has a list of community programs that people can participate in, the stepping on, the Otago, some physical therapy, that kind of things. And then, like Dr. Sanders talked about, the home assessment and some resources that they can do. And so I think that was Andy who said that if you're interested, I can get you some of those brochures, and just the education that there's other resources out there, I think is important.
Carly also had a question. It says, how many weeks, well, two things. One is there a cost to these programs? And then the second is, how many weeks is the Otago Fall Prevention Program? How long do they participate in that?
So there is not a cost. The Utah Department of Health and Senior Services puts on the Stepping On program, and there's not a cost for that. And Dr. Sanders, I don't know how long the Otago program is. Do you?
I think that Otago is 12 weeks, if I remember right. It's either 12 or 16.
And is it Chidi? Sorry, I don't want to mess up your name. As you had a question, go ahead and come off mute.
Sorry, I muted myself because I have a toddler by me. So my question is, I work at BMT, Huntsman Cancer Hospital. We have a lot of falls every month. And I just want to see whether there's any tricks or suggestion you can make regarding falls, how we can prevent falls. We've tried a lot of stuff. We do like close supervision, but we notice that there's still a lot of falls. Like for the last few months, we've had like at least 3 or 4 falls every month. So I came for this program to see whether there's a way I can help the unit, to see whether we can prevent the falls. I know we've tried to educate the patients, and what I notice is that mostly occurs at night, especially when they're confused. And also, I don't know, I think it's the chemo, but I'm just trying to see whether there's a trick. We have physical therapists that come every morning, every day to work with them, but I'm just trying to see whether there's a way you can share some tricks I can share with my department, a way we can prevent falls. Thank you.
So I will say that I am an outpatient person. I don't have a lot of knowledge on inpatient, so I will defer this to somebody else. Or Chidi, I could also put you in touch with some inpatient people that might be able to give you some information. But Dr. Sanders, do you have a?
Yeah, so the first thing that came to mind when you were talking was, and then you validated it when you said, oh, a lot of the times these falls happen when they're confused. The first thing that came to mind is actually trying to work on preventing delirium in those patients, and that's a whole nother topic, but delirium and falls are very closely linked, and they share a lot of the same risk factors. And one of the biggest offenders for delirium in older adults is medications. Just like one of the biggest offenders for causing falls is medications in older adults, or at least the thing that kind of tips them overboard, no pun intended. So that's the first place I would start. I know that the Huntsman is, we've been trying for a long time to get the hospital elder life program initiated over at the Huntsman, but it just really starting from scratch, working on delirium prevention is probably the first place I would start. And then also, I know right now it's tricky because of the visitor restrictions, but
yes, no family members. That's another worst thing that costs most of it.
Yeah. So but one of the big points in delirium prevention is really helping to keep patients oriented and working with them on that, and then again helping to avoid medications that could increase their risk for delirium. So even trying to redo orientation again before they're going to bed at night may be a kind of low-hanging fruit and something that you could institute pretty easily.
Thank you.
You're welcome.
So some of you can see we have launched the poll. We want to keep going with questions, but we have launched the poll just for our evaluation questions for those of you that need to leave. One other question that they had, especially for our university staff that are inpatient units, is how is this kind of program driven? Is it something that the provider would order? Is it something that a physical therapy order would be based on? How do they implement these programs and get our patients in these that are inpatient?
Are you specifically thinking about the community-based programs, Jane, like Stepping On and Otago? How do you get those referrals?
I guess I'll just unmute and ask.
Okay.
Being CVMU manager, one of our biggest issues is falls. We've had 3 major falls, one actually causing a death on our unit. And so we're really focusing in on preventing falls and how we can drive something like this is great. I mean, honestly, until this, I really thought that it was part of getting old. And this is such great information, even for me, for my elderly parents. I'm taking pictures and I'm like, I'm running to their house and letting them know they need to do this. But yes, for me as an inpatient nurse manager, this would be so helpful and such a great place to start. I mean, we're trying to think of devices to keep our patients safe, when it can be as simple as exercising and things like this. We could start reducing our falls so much quicker potentially, just by helping our patients. I mean, on the other hand, I think we have to look at the number of patient days they're here too, and how much we can really progress with that with our number of patient days. But it's certainly somewhere we can at least start and identify. So that's where I'm at with it.
That's great. And I think even the education component, that if you're leaving patients, if they can't see a physical therapist, if you're leaving patients with some of these ideas of exercises in that idea of prevention.
Absolutely.
So,
or they
super
can
helpful.
And then at least seek something outside once they are discharged. Love this. This is so amazing. Thank you.
Jane, the only other thing that I would add to that is, again, it's kind of two different topics in terms of trying to prevent falls in the inpatient setting versus the community setting. But falls in the inpatient setting, the first thing to think about is delirium, and preventing that. And so you're on CNC?
CVMU. And okay. Cardiac patients, I mean, they're walkie-talkie people.
Life program is on the on CVMU, and so that's a good place to start too.
This is great. Thank you.
All right, perfect. I know it is like right at 12:30. We like to be respectful of everybody's time. We know most of you are using your lunch hour for this. But definitely, are there any more questions for Natalie or Grayson? A lot of people just saying thank you, great information, really enjoying this. Like we talked about, we are recording this session. We will have our summer learning series and all of the links to our resources and things that we've talked about in our summer learning series up on our website. There might be a little delay because Emily and I are working on updating that and getting things moving. But we will have those available for you guys to view, to go back and view, or have somebody else view if they want to. So again, the evaluation actually is just, Chidi, is the polling questions that everybody completed. So now that everybody's completed those, Emily will be sending you guys out your certificates by the end of the week. And then we look forward to you guys joining us for our fall prevention series. Thank you, everybody, for joining us today. Thank you, Dr. Sanders. Thank you, Grayson, for joining us and giving a great presentation. We appreciate that.